Well, good evening, everybody. Welcome to this evening episode of Pursue, and we have Pursue 6M, which is liver, pancreas, and GI pathology. We are streaming live from Alsalam Hospital, Kuwait via Kolkata, and we will be continuing with our previous lecture of approach to small GI biopsies and polyp. This is session 2, and to talk on this, we have the expert, Dr. Rajaguru, who's a postgraduate from PGI Chandigarh at DNB, and at present is a specialist pathologist in Alsalam Hospital, Kuwait, a very reputed pathologist with interest in GI and liver pathology, with multiple international and national publications in liver and GI subject. Before I ask him to speak, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Rajaguru, sir, please share your screen and start the presentation. Thank you.
Hi, sir. Thanks for the introduction once again. I think you are able to view my screen.
Not yet.
Not yet? Okay.
It must be on the way.
Good to go?
Yeah, good to go, right? Yeah, you can make it. Yeah, that's fine. Please continue. Thank you.
Thank you, sir. So last session we had seen about the approach to small bowel, that is small intestine, and the stomach. So today we'll be talking about today I'll be talking about colon and rectum. So the next session will be about approach to the polyps. Here I would like to have it more interactive. So based on the replies, we will not spend much time on the photographs. So if we are not getting enough feedbacks from the audience, then we'll just move on. I need Nadeem sir's support for this.
No problem.
Go ahead.
No issues.
Yeah. So with in the colon and rectum, including the terminal ileum, usually we get the request form something like this, endoscopy shows an ulcer, patient has abdominal pain, and biopsies to rule out IBD, or erythema in the colon to rule out IBD. But some gastroenterologists give a more good description of what the findings are in the endoscopy, like there's erythema, friability, loss of vascular pattern, with a Mayo score, that is the endoscopy activity score. So with these, you get a more better idea of what you are going to deal with, like whether the part of the colon, which part of the colon is involved. Is it the rectum? Is it only the sigmoid or something proximal to it? Is it a contiguous involvement, or is it a skip lesion? Is it a kind of a well-defined ulcer, or just an erythema or friability? So a detailed description of the endoscopic findings will be very useful, especially when it comes to a standalone lab where you do not have access to the clinical file, the case file. And every time you might not, like to disturb the clinician by calling him or her to know the patient details. So, the developing a rapport with the clinician is very important, especially when it comes to GI biopsies. Can just ask them to, fill in properly what they are able to see, what they are seeing in the endoscopic picture, and also a brief history of how the patient presented, like whether the patient had mucus blood in the stools, or has alternating episodes of constipation or diarrhea, whether these events were acute or chronic, and so on. And obviously the age is also very important when we are dealing with any pathologies of the colon and the rectum. So again, age and sex, as I told, we should not wait to speak to our clinical colleagues. If in doubt, you always should speak to him or her and get it clarified, and always refer to the case file if you have the access to it. There are so many overlapping features when it comes to diagnosis of any pathology, and not only IBD. These things which I've described are very important before making a diagnosis. You'll know why in the subsequent slides, which I'm going to show you. In IBD, as I told, clinical findings, endoscopic findings, and histological appearance all together make the diagnosis. It is not only about the histological findings alone. The features of UC, that is ulcerative colitis, clinically they present with blood and mucus, and there is continuous involvement without skip lesions. Very rarely, in certain occasions, there can be skip lesions. I think there is going to be a session which is going to be completely on inflammatory bowel disease. So I'm not going into details of that. So the first site which is involved is the rectum, and then which goes it goes proximally from the rectum, and in certain cases you can have a cecal patch. That is, the rectum may be involved alone, and there might be a patch in the cecum which might show chronic active colitis, and this should not be considered as a skip lesion. It is called a cecal patch, and it is well known to occur with ulcerative colitis. And the small bowel is not involved, but still backwash ileitis have been can occur, and there are reports of upper GI involvement in ulcerative colitis as well, which will be dealt in the next lecture by the other doctor. So when it comes to histological features of IBD, diagnosis of chronicity and activity is important. The normal architecture of the colon is like a test tube arrangement, where the crypts are arranged parallel to each other, and they are perpendicular to the muscularis mucosa, which is seen over here. This is a properly oriented biopsy, and where you can see these crypts are parallel to each other, and the distance between the crypts is less than 1 crypt diameter. So that if there is an increased distance between the crypts, it means there is some amount of atrophy or chronic colitis occurring in the mucosa. So if it is a tangential or a cross cut, you will see this kind of crypts. Again, you see well formed rounded ones, like the way you see a linear arrangement of test tube from the top, not from the side and from the top. So here these crypts are rounded, well rounded, and what you see in between is the normal cellularity of the lamina propria with the lymphocytes and the plasma cells. So this is how a normal colonic biopsy will look like, and lymphoid aggregates are normally is seen in the right colon and also near the rectum. So you might see some amount of architectural changes, like distortion or crypt dilatation near the lymphoid aggregate. But in a non-inflamed mucosa, it does not have any significance, and occasional branch crypt also is not of great significance. So architecture is of three types: the distortion, branching, and atrophy. So distortion is irregularity or loss of the parallel arrangement, which I had shown you in the previous image. Variation in the size and the shape, where there will be enlarged crypt or a small size crypt. So this is variation in the size and shape, and dilatation, and tortuosity, like that of a secretory endometrial gland. So a tortuous gland is also a distorted crypt architecture. And branching, which where two crypts will be joined together. I'll show in the next image. The branching can be vertical or horizontal. Atrophy is when the space between the two crypts, between the adjacent crypts, is increased more than 1 crypt diameter. It means it is atrophy. And there is another description, that is shortening. So here what you see, this muscularis mucosa, the base of the crypts are resting almost close or in certain places on the muscularis mucosae. When there is shortening, this distance is increased, and this area between the base of the crypt and the muscularis mucosae is filled in by plasma cells. That is called basal plasmacytosis. So what is it? Like, there can be a minimal basal plasmacytosis which can be seen normally in the cecum and ascending colon. This mainly becomes a problem when it comes to diagnosis of Crohn's colitis, because the ulcerative colitis, we don't have problems because it is not going to involve the cecum. Means we are not going to have a problem because the rectum is going to show changes, and then only the cecum or the ascending colon. So we don't have problem in diagnosis. But when it comes to Crohn's disease, then we'll have to make sure that we find other histological features like a granuloma or chronic changes with active inflammation and so on. So we will have to keep in mind that a minimal basal plasmacytosis can normally be seen in the cecum and the ascending colon. In a properly oriented biopsy, this basal plasmacytosis can be very well appreciated. And if you do not find the muscularis mucosae like what you see here, and instead you see a tangential cut, you can also appreciate for what is called as plasma cell gradient. So usually what you see here, the bluishness gradually decreases from the top to bottom. This is called plasma cell gradient, where the plasma cells usually occupy the upper third of the mucosa, and it is more dense there, and gradually when it reaches the base, it is reduced. When it comes to an infective colitis, for that matter, the plasma cells are going to get increased only in the top layers, and the basal layers, this gradient will be very well maintained in an infective or a resolving infective colitis. Whereas when it comes to chronic colitis, this gradient will be lost. So that is that the plasma cells will be denser even in the lower third. So there will be loss of the plasma cell gradient, which can be appreciated in this tangential cut also. So that can be a useful marker to demonstrate basal plasmacytosis if you do not have a muscularis mucosa in the biopsy section. And another important feature is the Paneth cell metaplasia, which has significance when it is distal to the splenic flexure. So before that, that is in the transverse colon, up till the transverse colon, it is normally present, and after the splenic flexure, presence of Paneth cell metaplasia is abnormal. And the mucosal villiform appearance, which can be seen over here, very minimal, not very marked, is a feature of chronic colitis like ulcerative colitis. So this is a classic case of ulcerative colitis, where you can see this minimal surface irregularity, and as I told you, the gradient of the plasma cell gradient is completely lost. You see the mucosa, that is the lamina propria, is completely blue here and uniformly blue. So there is no increase in the top alone and reduction in the bottom. And what you see here is the distance between the muscularis mucosae and the base of the crypt is increased, which is replaced by lots of plasma cells here, and this is called basal plasmacytosis. And the distance between these two crypts, or between this crypt and this crypt, is markedly increased. So there is atrophy, shortening, dilatation like what we see here. We're not able to see good branching in this biopsy, but all the other changes are seen here. And one thing to be noted about is that, see, this inflammation is restricted to the lamina propria. It is not seen crossing the muscularis mucosae and into the submucosa, which is a feature of Crohn's disease. This submucosal inflammation is not a feature of ulcerative colitis. There are certain cases, rare cases, fulminant ulcerative colitis and toxic mesocolon you can have, but I think they'll be dealt in the next lecture. So for now, like, if you find in a small biopsy, inflammation spreading through the muscular mucosae into the submucosae, you have to have a suspicion of Crohn's disease, because endoscopically you might have a rectal alone involvement, and the other site may be somewhere in the small bowel, which might not be biopsied at all. So, a suspicion of Crohn's disease should be there if there is inflammation which is seen spreading across the muscularis mucosae. So, this is Paneth cell metaplasia. You can see here. So, I just want to stress a point here that the Paneth cells should be differentiated from the neuroendocrine cells which can be seen, and these neuroendocrine cells also have this eosinophilic cytoplasm, but these are seen towards the outer surface, towards the lamina propria, but whereas the Paneth cells have eosinophilic cytoplasm towards the lumen. So this is a differentiating feature which helps a lot, because the presence of Paneth cells indicates that it is a chronic colitis. There are chronic features, but neuroendocrine cells are normally present. Then comes the activity. So, for the main important thing for the diagnosis of IBD is the chronicity. Activity is more or less, endoscopic assessment. Whatever degree of activity we give, it depends upon what they are going to see endoscopically, if there is ulceration or erosion or friability. Usually they do not biopsy at the specific site of ulcer. So, in a small biopsy, we might not be able to see an ulcerated lesion, whereas actually there might be an ulcer. But however, this is according to the British Society of Gastroenterology, that the activity is graded as mild, moderate, and severe based upon the extent of cryptitis, cryptapsis, presence of surface erosion, and ulceration. So if it is mild when when the cryptitis is less than 25% or less than 10% of cryptapsis, and moderate if the cryptitis is more than 25% and more than 10% cryptapsis with focal erosion, and severe if there is multifocal erosion or ulceration. This is mainly of importance when it comes to follow-up biopsies, like when a patient is treated for ulcerative colitis and a repeat biopsy after treatment is performed, and to demonstrate deep remission, that is histological remission, they ask for activity, and it is like when you do not find any neutrophils at all, you can just say that a quiescent phase of ulcerative colitis. You just find that there are some distortion of the crypt architecture, but the inflammatory cells, including the plasma cells, aren't increased, and there are no active inflammations. Then you can say that maybe consistent with deep remission, or histologically does not show any activity. So that can be told. And this is again by the British Society of Gastroenterology, where they have a mnemonic that is the paid I. P stands for pattern, A for activity, I for interpretation, D for dysplasia, and I for inclusion. This acronym is very useful because you don't miss out anything. Like P for pattern, you have the chronic changes where it shows where it is, the presence, the distribution, and the extent. Like suppose if the biopsy is from the rectum and sigmoid, so you can say the rectum alone is involved, and the sigmoid is spared. So the chronic changes are present, and it is restricted to the rectum. And in that rectum, whether it is seen throughout or it is patchy and focal. So these has to be mentioned, because when it is ulcerative colitis, the biopsied site is going to show changes which will be seen uniformly in all the biopsy fragments. But when it comes to Crohn's disease, it might show patchy and focal involvement at that particular site of biopsy. Suppose like if the biopsy is from ascending colon or transverse colon, there are like suppose 5 punches taken from that, and all the punches might not show uniform changes. One punch might show a lot of changes with chronic active changes. The other fragment might be completely normal, whereas the other fragment might show minimal to moderate changes, like that. Whereas in ulcerative colitis, all the 5 punches taken from that particular site of involvement is going to show uniform changes. And then the activity, you have to grade it. Then you have to give your interpretation, that is whether it's IBD or not, first of all. And then you favor ulcerative colitis or Crohn's disease. Then D for dysplasia. This is useful mainly when it comes to a diagnosed case on follow-up. And then again, a CMV inclusion is going to be for a patient on treatment. Very rarely that like certain cases of CMV colitis can show changes similar to ulcerative colitis with chronic active changes. So I'll be starting with a case here, a 48-year-old male with ulceration and erythema on the sigmoid colon to rule out ulcerative colitis. So this was the finding which was given on the request, and the histological biopsy showed this kind of picture. So I think you are able to appreciate the uniform increase in the lamina propria cellularity, and there is some area where you can see basal plasmacytosis, though not so very classical. There is a basal lymphoid aggregate, which is also a feature which favors ulcerative colitis. And here you might see a bit of branching here, and there is definite architectural distortion. There is some amount of atrophy of the crypts, and then the crypts are widely spaced from each other. Here again you can see some branching, and there were a total of 2 fragments from this site, that is the sigmoid. And what you see, first of all, you have a history, that is the site is from the sigmoid. And next, I had 2 fragments. One was showing this kind of changes, and the other showed these changes, where you see that the inflammation was not markedly increased compared to that particular fragment, and the architecture is more or less maintained, though there are like some amount of distortion, but more or less they are like okay, preserved kind of. So here you do not see, a very classical feature of ulcerative colitis for the fact that the rectum is not involved, the rectum is paired, sigmoid is showing changes, and it is not diffused. One fragment is showing changes which is looking like a chronic active colitis, whereas the other fragment looks more or less okay. So now what are the DDs and what you will like to do? Anyone is going to answer, or then
let's wait a minute. There is a significant lag today with Google Meet and YouTube. Probably the internet speed across the country is slow, I think. I'm following both. I can see that in the YouTube there's an element of, but anyway, the Google Meet people can respond right away.
Yeah.
They can have a look and give an opinion what is their DD.
Yeah. So
there is nobody responding here.
Okay, fine. I'll go ahead there.
Yeah.
So as I said, when the changes are not global, that is involving all the fragments, then you will have to doubt the diagnosis of ulcerative colitis. And again, here the involvement is sigmoid. So one possibility is that the patient might have Crohn's disease. So, but then I did not find any granuloma. So I was left with, the best thing which I can do is like go and refer to the patient's file and see the endoscopic report. So when I checked the patient's file, so there was diverticulosis. So in that case, the diagnosis would be segmental colitis associated with diverticulosis, where the changes can be much like inflammatory bowel disease, that is ulcerative colitis with chronic active features, but the changes might not be uniform in all the fragments as I told above. So this has to be kept in mind. So this is a case of segmental colitis associated with diverticulosis. So there is the next case, 35-year-old male with ulcer in rectum to rule out ulcerative colitis. So this was the DD. And what we got over here is like there is again a lot of inflammation in the lamina propria. The crypts, there is not much of distortion, but there is enlargement and some dilatation here and there. Maybe there is focal basal plasmacytosis, but there on the surface there is some kind of a pinkish exudate. So it didn't look so good, and there was some neutrophilic exudate as well, and this pink exudate had kind of this structure. So there aren't enough responses, so I'm just moving ahead. So what I would like to do is, like, whenever there is some element of doubt, I don't mind going ahead for serial section and deep cuts. So mainly for a small bowel biopsy, small biopsy from the GI, I would like to do a serial section, at least 3 or 4 of them. Usually I get 4 sections per slide to have a kind of a deeper view of the tissues. But if there is an element of doubt, I always like to go and do more sectioning. And when I did, and I found out this, and this is a beautiful amoebic ulcer it is. So I think no one will have a doubt in diagnosing this. But all we need to do is just to have an idea that amoeba also can present like an IBD. Clinically, endoscopically, maybe they would have missed because the patient was having a rectal ulcer. But like if we know that it can present like and look like an IBD with some chronic features like distortion and basal plasmacytosis, we can pick up these. So we'll have to keep in mind of amoebiasis also. In another case, 45-year-old female with a known case of ulcerative colitis presented with worsening bowel symptoms. So the sections were like this. There is the architecture is like mildly distorted. The lamina propria was edematous with a volcano kind of ulcer with neutrophil-rich fibrinous exudate coming out like a flower pot, and more sections showing the similar kind of changes. So it is a pseudomembranous colitis complicating ulcerative colitis, which is well known. It is seen in patients with ulcerative colitis treated with antibiotics or an immunosuppressive agents or corticosteroids. So they might have gastrointestinal symptoms, and we will have to look in for these also. Maybe in certain cases, we might not be able to find a classical pseudomembranous area, but whenever you find some fragment which has the neutrophilic fibrinous exudate, you can advise the clinician to check for Clostridium difficile toxin. So moving on to the next case, 50-year-old male with the bleeding PR, erythema and erosions in the sigmoid colon. So again, the doubt will be to rule out IBD or not, but what we'll have to note is that this is the sigmoid colon. So probably could be a Crohn's or other kind of colitis. So when we go here, what we find is a well-preserved architecture of the crypts, but there is a lot of hemorrhage here, and then there is lamina propria hyalinization going on. The crypts appear atrophic, dilated, and there is withering of the epithelial cells from the crypt the lumen. And when you go higher, there are lots of atrophic crypts and withering. There is loss of the goblet cells in the other neighboring crypts, which are looking fine. And when you did trichrome, there is so much of hyalinization going on. So this is a case of ischemic colitis. So ischemic colitis usually involves the splenic flexure, the watershed area, rectosigmoid or the ileocecal region. The early feature will be loss of mucin, goblet cells, and reactive ATP of the crypt epithelial cells. So the crypt epithelial cells are going to look like going to have a morphological appearance of an adenoma, though the nuclear stratification might not be there, but there might be enlargement and presence of nucleoli, and might look bizarre. So you have to have this in mind and looking for goblet cells. So and other features like lamina propria hyalinization. So that could be a ischemic colitis. So whenever you have an ischemic colitis, look out for presence of vasculitis or amyloid deposition, where these both can result on ischemic colitis, particularly when the sites are not from these which I have mentioned, like splenic flexure, rectosigmoid or ileocecal region. Ask for history of radiation if the changes again are present at all sites, apart from those which are mentioned here. And if you find the apoptosis to be increased, or if you find endothelial cell ATP or some bizarre nuclei, so you will have to have a differential of radiation-induced colitis also. So when you ask for history, you can solve that. And two infections can have features which look like ischemic colitis. One is the E. coli infection, particularly the O157H7 strain, and specifically you will be able to see some microthrombi in the superficial capillaries of the lamina propria. But again, you will be able to see a lot of neutrophils in the lamina propria in an infectious colitis. But ischemic colitis also can have neutrophils with pseudomembrane formation. The main differentiating feature is the absence of lamina propria hyalinization, which can be demonstrated by a trichrome in an infectious colitis, whereas the ischemic colitis will have lots of lamina propria hyalinization, so which can be demonstrated by trichrome, which is shown in this picture over here. So that will be a useful point to differentiate both. So going on to the next case, 29-year-old male with altered bowel habits. So the clinical diagnosis was irritable bowel syndrome, and random colonoscopic biopsies were performed. And what you find here, the crypts are all fine. The surface epithelium is okay, and there is nothing here. This is normal collagen. Inflammatory cells are okay. No, there's no increase. Architecture is okay. There's nothing much going on here. But when you go to the surface, you find the surface not so good. It's a bit fuzzy. Looks like something is sitting on top. So when we went ahead and did some special stain, these were found to be positive for PAS. So this will be, if we do a Watson study, it will highlight it more well, so but I don't have that. So did a GIMSA again, which highlighted it better. So this is a case of intestinal spirochetosis. It can be seen in the developed and developing world, maybe due to fecal contamination or like the improper hygiene. But in the Western world, it's usually seen in the homosexuals. So this also you can have in mind. Very rarely these have invasive features with lots of active inflammation, but most of the cases are asymptomatic and can be treated well with metronidazole. But when you report this, make sure that you don't overcall a prominent brush border on the surface epithelium or mucin or a normal commensal which is sticking onto the the surface epithelium for the intestinal spirochetes. So maybe you can do the special stains and confirm the same. Going on to the next case, 35-year-old male female presented with ulcer in the rectum. So this is a very classical case of solitary rectal ulcer syndrome, where you have the surface epithelium which is denuded, the lamina propria which is replaced by fibromuscular stroma, and you have a disorganized crypt architecture. You can see it very well here, and the capillaries are dilated and congested over here. So this is a classic case of ulcer syndrome. So this is another case. If the people are a bit active, if someone from the audience can just tell what this could be. Or just shall I move ahead? Okay, so this is a case of diversion colitis, where you get a lot of lymphoid aggregates, reactive lymphoid aggregates in the lamina propria, which will be basal, and this is from the pouch which has been created. I have not given notes about this in the next subsequent slide. I'm just going to describe this. Patient who has undergone colostomy, and the part of the redundant bowel, the pouch, from which there might be blood and mucus. So biopsy might be performed to rule out, inflammatory bowel disease. So the diversion area that the pouch might show these kind of changes with the reactive lymphoid aggregates in the base, and some architectural changes of the crypts. So when you get a biopsy from the pouch, you have to keep in mind about diversion colitis also. So this is mainly due to the absence of short chain fatty acids, because the food and the microbiota is diverted from that particular segment. So you will get changes like this. So this is another case. So I have not given the history, but I thought I will get some inputs from the audience. So I just put it like this. So I'll just describe it for you. So here the architecture is more or less maintained. So there is not much architectural distortion. The inflammatory cells are increased with lymphocytes and plasma cells, not much of neutrophils. But when you go to the surface here, in the low power, you can see there is some kind of attenuation of the mucosa, there is some leukodepletion, some loss of couples. But when you go to high power, you can see a lot of intraepithelial lymphocytes in here. There is intraepithelial lymphocytosis with epithelial cell damage in the form of cytoplasmic calculation, and nuclear changes also. Some apoptosis also has been in the surface epithelium. So this is a case of microscopic colitis, but it is not a direct diagnosis without history. If a site is given without history, it is not right to make a diagnosis of microscopic colitis, because these kind of changes can be seen in a resolving infective colitis also, and in cases of NSAID intake, when the non-steroidal anti-inflammatory drugs are taken on a chronic basis, so you can have these kind of changes. So history is that the patient will have a typical chronic watery diarrhea, and endoscopy might look normal. So that is why it is called microscopic colitis, this lymphocytic colitis. Although certain cases might show some edema and mild erythema. Again, as I told you, will have to rule out the infectious etiology, whether the patient presented acutely, and then have to rule out history of NSAID intake. And not only the presence of increase in IES is important, we will have to demonstrate the epithelial cell damage also, like flattening of the mucosa, mucin depletion, vacuolation, and nuclear irregularities. While counting intraepithelial lymphocytes, you have to stay away from the lymphoid aggregates. But when the intraepithelial lymphocytes are seen at the place of lymphoid aggregate, those areas are not going to show epithelial cell damage. So you really don't have to be worried about them. And even though if the biopsies are so superficial, you can just make use of this feature, that the absence of epithelial cell damage, if it is not there, it is not a lymphocytic colitis. And as I said earlier, that the cecum, ascending colon, and rectum might show lymphoid aggregates normally, so you will have to make sure that you're not going to count the intraepithelial lymphocytes at that particular area. The involvement can be patchy, so you will have to look in for all the fragments in a biopsy. Like sometimes you might get a segmental colonoscopic biopsy, or you might get multiple punches put in the same bottle. So you will have to check all the fragments, even though they might look normal on low power. Just try to look in for any increase in intraepithelial lymphocytes or increase in the subepithelial collagen thickness. The lamina propria will show increase in cellularity with plasmacytic cells and neutrophils. There can be even cryptitis in crypt abscesses. So likewise, microscopic colitis also is composed of collagenous colitis with increase in subepithelial collagen thickness, that is more than 10 microns in thickness. And in this collagenous colitis, you will always demonstrate increase in intraepithelial lymphocytes with epithelial cell damage. So when you have a kind of subepithelial collagen kind of thickness without increase in intraepithelial lymphocytes, you have to doubt the diagnosis because it might be due to some other cause, like it might be an ischemic colitis, like what we had seen in the previous case, or it can be a radiation-induced colitis or amyloid deposition. So when you don't find the intraepithelial lymphocytes in a collagenous colitis, then you will have to think of other causes. There are various drugs which have been implicated in microscopic colitis, mainly the NSAIDs, the proton pump inhibitors, the ranitidine, the H2 receptor antagonist, SSRIs, then statins also have some significance. So if you diagnose a case of microscopic colitis, you will have to speak to the clinician if they have any history of these drug intake. So maybe they can modify the treatment based on their diagnosis. So moving on to the next kind of section, this is pill fragment associated colitis. So I have not seen a case for myself, though I have seen a lot of cases in Twitter and online. So this is caxylate-induced colitis. Caxylate is a drug which is used to treat hyperkalemia in chronic renal failure, and they they can cause ischemia and ulceration in the colon. And there is another drug, the sevelamer, which is used to treat hyperphosphatemia. But colonic involvement is debated. Some people say that it does cause ulceration, but it is not proved. Bile acid sequestrin, which is used to treat hyperlipidemia and used for treatment of chronic liver disease and bile acid malabsorption, can also be seen, but they do not cause any injury. So in this picture, what we see is the caxillate, and then this is the cevilamer, which is yellow in color, yellow-pink crystal, yellow or pink crystals are cevilamer, and bright purple crystals are caxillate. Now, mainly they have to be differentiated. As I told you, that caxillate are the ones which cause ischemia and ulceration, and with AFD staining, they appear black, whereas cevilamer appears magenta, and bile acid sequestrin appear dull yellow. The NSAID intake can cause focal active colitis. As I said just before, it can cause increase in intraepithelial lymphocytes. It can cause astroid superficial deep ulcers. They can cause chronic colitis like picture, mainly in the right colon. We should not get confused if it is a Crohn's disease or not. Like maybe other features might really help. So that is why, without finding a granuloma, usually I refrain from the diagnosis of Crohn's disease. Like until unless I find a granuloma plus other chronic active features, then I give a diagnosis of Crohn's disease. So if not, I just stay away. And then it can involve a focal area in the colon. So it is not going to involve multiple sites. So maybe the right colon is more frequent. So NI causing chronic hepatitis also has to keep in mind. So the next drug is macrophiliate hospital, which is immunosuppressant, which is used to prevent infection and graft-versus-host disease, and used in various countries. So this can cause changes, may make ulcerative colitis or Crohn's disease and even graft-versus-host disease. So we had a case, unfortunately, it don't have the names for this, but it was having typical chronic colitis picture with small granulomas in the biopsies, and but the patient, I had suggested the delineation was saying that the clinical presentation is not like those, and he's very sure about that. Patient was a renal transplant recipient. So while going through the literature, we found that even microphenolate mofetal can cause some granulomas, which is similar to that of Crohn's. So and the patient showed significant improvement. So this has to be kept in mind. And you always will find increase in the apoptosis. We saw all the certain induced enteritis and enteropathy and autoimmune enteritis, where we saw a lot of apoptosis. So the apoptosis here in colitis, for that matter, is going to be increased. So where this chronic active or active colitis, you just have to try looking for increase in apoptosis, and if they are increased, then you will have to try to get in some clinical history. So maybe there is not going to be no, I'm sorry, that to differentiate from GHT, the GVHT, that is graft-versus-host disease, there are certain features, but since you're going to use this drug, I don't think so graft-versus-host disease will come under the differential, but graft-versus-host disease will show a lot of microtic apoptotic figures which look like microabscesses, which I'll show you later in the image. And the eosinophils will be increased in the microphenolate mofetal, and there is going to be neuroendocrine cell aggregate in graft-versus-host disease, because those are resistant to destruction. So those will be appearing prominent. That is, the neuroendocrine cells will appear prominent, and they may appear as aggregate in graft-versus-host disease, but whereas in a mycophenolate mofetil, they are not going to be very obvious or not going to be present as an aggregate. So these are features with which we can differentiate both of them. The other is the PD-1 and PD-L1 antagonist drug-induced colitis, which is a new drug used for treatment of various carcinomas like melanoma, non-small cell lung carcinoma, and renal cell carcinoma. It can cause acute colitis or a lymphocytic colitis like pattern. Again, here the apoptosis is going to be increased, like what we see here. A lot of apoptosis here and here. Here the lymphoplasmacytic cells are increased, and you have some active inflammation as well. And this is a kind of an atrophic crypt. This again is an atrophic crypt, and the main important thing are the apoptosis once again. So this is what you're going to see, and like there are other chemotherapeutic agents like CTLA4 antagonist and PI3K inhibitor also can cause colitis. History is very important, and finding apoptosis is also very important. So last time we saw a case of common variable immunodeficiency where we saw a lot of giardiasis in the small bowel with villous atrophy and lack of plasma cells in the lamina propria. So as I said, the small bowel and the colon plasma cells are normal constituents. So if they are absent, then you will have to consider this diagnosis. And in a case of parasitic infection, where the history is not like suggestive of having, the patient is not suggestive of having the infestation, like if the patient is negative for HIV and if patient is not a transplant recipient, you can consider the diagnosis of CVID and like advise the clinician to do a serological study, because around 30% of these patients can show normal amount of plasma cells in the colon or in the small bowel. So they may be not producing the immunoglobulins, but the plasma cells might be normally present. So you can advise your clinicians for that. And what you will find is decrease in plasma cells, lymphoid aggregates, increase IELs, increase in apoptosis. Granulomas also can be found. In small bowel, there might be some villous blunting, and in colon and the small bowel, there can be some increase in the subepithelial collagen thickness. So, going on to graft-versus-host disease, this is a case of GVHD where you find the crypts showing lots of apoptosis and thereby atrophy and epithelial cell loss. And you see this over here, this is a neuroendocrine cell. Again, this is a neuroendocrine cell which have survived the insult, and so in certain cases they might look like an aggregate. So this is what it is. And in GIT, it can involve the esophagus, the stomach, the small bowel, and the colon. The main thing is that the inflammatory cells might show opacity in the lamina propria. It might not mimic active or a chronic active colitis. All what you will see will be atrophy with increased apoptosis. Like I forgot to tell you that like apoptotic micro abscesses will be formed. That is, the micro abscesses will be plenty, and it will look like a abscess with a cavity and a lot of these apoptotic fragments. Not so classical here, but you can still see that it is a kind of a vacuole with a lot of these nuclear debris inside. So whenever this is exaggerated, it is called an apoptotic microabscesses. So there is a system for grading, the learner system, where grade 1 stands for crypt apoptosis without crypt dropout, and grade 2 for a single crypt dropout, and grade 3 for contiguous crypt dropout or focal microscopic mucosal ulceration, and grade 4 for diffuse crypt dropout with ulceration, like what you find it over here. So when you find a increase in the apoptosis in the crypts, what all you have to keep in mind? The first thing is the bowel preparation induced changes like sodium phosphate enema or oral sodium phosphate intake for the bowel preparation. So what you will be able to find is there might be lamina propria edema, superficial hemorrhage, some amount of mucodepletion and focal active colitis, maybe some cryptitis also. But these can be easily differentiated from other drug-induced colitis which we had seen just now. And the other thing will be GVHT, and next will be CMV. So we will have to keep in mind about the cytomegalovirus infection also. In pediatric patients with the picture like an inflammatory bowel disease with increased apoptosis and not showing any response to treatment, conventional treatment, you will have to consider the possibility of autoimmune enterocolitis. Definitely the small bowel is also going to show involvement, but this has to be kept in mind. In adults, it will be usually the drugs. So you will have to find out the drugs by speaking to your clinical colleagues. So next I'm going to show a case of a 25-year-old male with bleeding the rectum. Query ulcerative colitis is the diagnosis. So this is the photograph, micro photograph of the biopsy, where you see the inflammatory cells are markedly increased in the lamina propria. The crypt architecture is more or less maintained, but you see there's a lot of atrophy and there's spacing between the crypts, adjacent crypts. But I think if you remember the first biopsy which I showed you, a classical case of ulcerative colitis where the inflammatory cells were confined to the mucosa, they were not crossing the muscularis mucosae. Here what you see that these inflammatory cells are spreading beyond the mucosa into the lamina propria, into the submucosa, breaching the muscularis mucosae. So you will have to think of another diagnosis in this setting, a young male with ulcer in the rectum with a lot of plasma cells and the inflammation spreading on to the muscularis mucosa. Definitely Crohn's colitis is a differential diagnosis, but like when you go to higher power, what you can see is there's a lot of plasma cells in the lamina propria, and then there's some kind of a vague epithelioid cell collection. So, fine. So, Dr. Nadeem, sir?
Yes, please.
So, are there any feedbacks in the YouTube or somewhere?
A lot of questions on the YouTube.
Okay,
I will tell you the question. I've sent the question on WhatsApp. I've taken a screenshot and we will take the picture once it's finished.
Fine. So, okay, fine. This case is someone ready to answer this. Like we had seen that there's a lot of inflammation which is crossing the muscularis mucosa, involving the submucosa, a plasma, and
Hello.
Yes.
Hello. Sometimes coming in some point. Yeah, now it's there.
Okay.
Hello.
Yes, sir. Yeah. So this is like up to the weight.
Please go ahead.
Yeah. So as I said, this is I will talk about findings. I will see what and this case of particular effect will after we when not by and to be something to months slow and then
Your voice
okay,
is breaking. We can't hear- yeah,
second, one second.
your voice is
We'll just try.
breaking.
Quickly, we'll move on the infectious. So last time we had a question about Sarsilatin ventricular infection, the significance of that. So from a patient, uh, a female of 60 years old, where we found these organisms which are in tetrad or octet in configuration, typically the cocci, which will be seen on the surface of the gastric epithelium. These are nothing but Sarcina ventriculi infection. They are anaerobe, which will be present in the soil, and they have an ability to survive even in low pH. They are usually an innocent bystander and does not cause much of changes in the gastric mucosa, but they have been seen to be associated with gastroparesis in patients with gastroparesis or gastric outlet obstruction, and in certain cases they have been implicated in causing emphysematous gastritis, and in livestock they have a role in gastric dilatation and even in death of the livestock. So when there is a presence of these organisms in a gastric biopsy, it will be necessary to investigate further for anything abnormal, that is like the cause of which is causing gastric stasis or gastroparesis, and has to be treated because there is always a risk of emphysematous gastritis. So that has to be conveyed. And this was an article which was published by one of my friend, Dr. Balan. So he has the same opinion, like that the presence of these organisms has to be documented, uh, as the patient might need further workup, and also has a possible association with the emphysematous gastritis. Hence, it has to be reported in the routine reporting. And moving on to the next case, if we have any comments, then if someone can, tell what these are on the left and what is this on the right. If anyone can comment.
Just hold on, let's see.
So
I think there are none. We can go ahead.
So we are dealing with the infections of the GIT. So this is a CMV infection of the colon. So we can see intranuclear as well as cytoplasmic inclusion in the endothelial cell and the stromal cell. Whereas this is a ganglion cell. So when it comes to diagnosis of CMV, we'll have to keep in mind of the ganglion cells, which can also be seen in the lamina propria or the muscularis mucosa. So that has to be kept in mind. And this is a case I thought if someone would answer, but since there are no good
So
response, so just
there is a response from the YouTube's. Dr. Nabanita Das had said it is CMV.
oh, great, that's
Yeah.
great. So this is another case. I think you can make out this is an esophageal biopsy, and there is quite a lot of inflammation here, and the epithelial cells show multinucleation, and there is definite intranuclear inclusion. Uh, this is a case of HSV.
Yeah, it is HSV. Yeah. I thought somebody from the YouTube would answer that.
Fine.
Let's wait. No, there is none. So yeah, it is HSV. Yeah. Go ahead, please.
HSV esophagus.
Yeah.
And I'll wait for this, sir. Yeah, this is another case. This is a duodenal biopsy. If someone is going to
Yeah.
answer for
The previous case, from the YouTube they've answered. Dr. Komudi Patnaik said herpes,
oh, that's great.
and so did
Okay.
Nabanita Das. Actually, there's a slight lag, which is
Yeah,
occurring
there is a
today.
slight lag, and I think I'm not patient enough.
No. I can understand. If you can just wait for this, because this is very interesting. I can see a lot of
Yes, sir.
things.
Yeah.
Yeah. So if somebody could answer in the Google Meet, so many people they can answer, and there are a lot of people in the YouTube.
Yeah.
Let's wait and see what they have to say.
Yeah.
Strongyloids.
Strong lights.
Komudi Patnaik said strongyloids.
Very good. Yeah, that's right. Absolutely. But it might not be as heavy as this in most of the cases. So just keep in mind about this also.
Yeah.
So this is another. So we are dealing everything about infections of the GIT. So again, I'll wait for this. I'm giving a hint. So I think you'll be knowing that this is a small bowel biopsy.
Dr. Nabanita has ankylomas from it.
No, that case we've crossed, and that is strongyloids stercoralis.
Yeah, just strongyloids. Yeah. Yeah, Dr. Nusrat Sayed says strongyloids. Yeah, let's go ahead. Yeah.
Sir, so this is the next case.
I think we can go ahead. Yeah.
Yes, sir. So this is a duodenal biopsy where you find villus blunting, and you see a lot of these foamy histiocytes in the lamina propria, and with some, I guess there are some dilated lacteals also. So when you get a lot of foamy histiocytes in the lamina propria, we'll have to think of two things: foamy histiocyte looking cells. So we either it is a Whipple's disease, or is it a mycobacterium avium complex infection, MAC, particularly in an immunosuppressed patient. So when we do a PAS stain for Whipple's disease, it is going to show granular positivity in these foamy histiocytes, and whereas in a MAC infection, those are going to be rotted. And again, when you do an AFD, the MAC is going to show positivity, whereas Whipple's will not be showing any positivity. So these should not be confused with the xanthomas, which usually occurs in the stomach, the gastric xanthomas. When you do a PAS, negative for the PAS. So this is the main differential there. So this is another infection which usually affects the immunosuppressed. These are not to be confused with the apoptotic bodies. These are not within the epithelium. These are seen lining the surface epithelium. These are some other infection, the microsporidium and the isospora, which I have not covered. So this is a last case recently got biopsy from the cecum in a 45-year-old female. So if anyone could tell what this is, then we'll close the talk with this.
Actually, your slide is not we can visualize your slide.
Okay. Is it not clear?
We can hear you, but we can't see your slide. So we do
Okay.
it's not coming. Yeah, just can go one slide back.
Yeah.
It's not coming. I mean,
So
there's some internet issues going on. Some issues there. We can see a stronger lower right now.
Oh my god. Okay. So
that is not changing. Wherever in the YouTube there's the slide changing. Cast these slides.
so shall I exit, stop sharing, and then start sharing again? Once again, shall I try that?
Yeah, you can even exit and come in again.
Hello? Hello? Am I audible now? Is it clear? Hi, sir. Am I audible? Is it clear now?
Hi. Yeah, it's much clearer. Yeah.
Can I
Can you
just,
hear me?
yeah. Are you able to see my PowerPoint?
No, you past presenting. We can't see your presentation. Just start presenting.
Yeah.
Yeah,
I-
now we can see.
Yeah, fine. Okay. So we have crossed the strongyloids and then we have moved on to the next case. This is a duodenal biopsy. Shall I wait for someone's reply for this?
No, please go ahead. Please go ahead.
Okay. This is a case where the biopsy is from the duodenum. You find a lot of foamy histiocytes within the lamina propria. And when you get this kind of picture, then there are two infections which has to be kept in mind. One is the Whipple's disease, and the other is the Mycobacterium avium complex infection, which happens in immunosuppressed patients. So when you do a PAS in Whipple's disease, you get a lot of granular positivity in the cytoplasm, and whereas you get rod-like positivity in MAC infection, and when you do an AFB stain, the Whipple's disease is going to be negative, whereas MAC is going to be positive. So this should not be confused with the gastric xanthoma. Xanthomatous, like usually xanthomas occur in the stomach, where you get these similar foamy macrophages, but the PA stain is going to be negative for that. So the cryptosporidium infection is going to be seen along the surface epithelium. These are like small round shaped structures which can be confused with the apoptotic bodies. So when you find this, do not confuse that with apoptotic bodies, because apoptotic bodies are going to be seen within the epithelial cells, but cryptosporidium will be seen along the surface or in the lumen of the crypts. So they shouldn't be confused with apoptotic bodies. And this is the last case from me today. So recently we have got a biopsy from the cecum of a 45-year-old female. So anyone with a diagnosis for this?
I think there are you can carry on.
So this is what we were interested about. This is nothing but schistosomia infection, so which has involved the colon also. So this is all from me for today.
Thank you so much, Dr. Rajaguru. We had. Hello, can you hear me?
Yes, sir. Yeah.
Yeah. Thank you so much for this wonderful presentation. We had some internet issues, which it went a bit, wayward. But that's
Correct,
okay.
yes.
I think everything has been recorded. I think people can see the recording and a very smooth way, no issues in that. Wonderful presentation. You have explained things very, very nicely, very vividly. Thank you so much. Hope to see you with the polyps, right?
Yeah.
Next,
Yeah.
I think that's on Friday. Is that right?
Yeah, on Friday.
Yeah, right. Okay, then take care. Bye.
Thank you, sir. Thank you so much. Bye.
Thank you. Bye. Bye.